Good afternoon, everyone. Welcome to our weekly academic activity. Today, our topics will start with the systolic anterior motion with Dr. Mohammed Al-Aboud, and then we'll go to the hypertrophic cardiomyopathy by Dr. Ayat. Then we'll finish with the journal club with the partner trial with Dr. Abdurrahman Al-Raweri. Dr. Mohammed, please prepare your slide. We'll start after 5 minutes, inshallah.
السلام عليكم.
وعليكم السلام ورحمة الله.
عبد الملك، نبدأ أو نصبر شوية؟
1 minute.
Sure.
We'll start.
Please let me know.
محمد تفضل, you can start.
Bismillah. Assalamu alaikum. Good afternoon, everyone. I'm Mohammed Al-Aboud, cardiac surgery resident from King Faisal Specialist Hospital and Research Center. I have, or I'm pleased to announce that Dr. Shahid may, to me, a senior consultant cardiographer and cardiologist at our center in King Faisal Specialist Hospital. She is having a long experience in the field of the cardiology and the echocardiography over 30 years. I hope that she is gonna be a great help for understanding the systolic anterior motion and generally echocardiography about it, and the hypertrophic cardiomyopathy, including obstructive type. So my objectives today, I'm gonna have an introduction about the topic, and then we will touch some slides on incidence, and most likely concerning about the incidence of SAM in hypertrophic cardiomyopathy and post-mitral valve surgery, particularly mitral valve repair, as it is have significant incidence in an experienced hand. We will touch on pathoanatomical mechanisms that can contribute and lead to systolic anterior motion of mitral valve, and we will touch on the imaging modalities and risk assessment by Dr. May Shahid, and we will speak generally about the management of such entity. So to start, the systolic anterior motion describes the dynamic movement of the mitral valve during systole anteriorly towards the left ventricular outflow tract, and that can cause or might lead to obstruction of the left ventricular outflow. The systolic anterior motion was first documented by Termini et al. 4 decades ago, and let me tell you that it was initially considered to be specific to hypertrophic cardiomyopathy, but is now recognized to arise in any setting that alters the complex dynamic anatomy of the left ventricle. Although early reports identified the ventricular outflow tract obstruction to occur in all cases of systolic anterior motion, it is now understood that its presentation can vary from clinically silent disease to severe LVOT obstruction with associated hemodynamic compromise. The systolic anterior motion is predominantly observed in patients with a hypertrophic cardiomyopathy, where it was originally considered to be pathognomic for this disease, or after cardiac surgery, specifically mitral valve repair, typically. It occurs in 31 to 61% of hypertrophic cardiomyopathy patients, where it is associated with resting LVOT obstruction in 25 to 50% of cases based on several series. After the initial description of systolic anterior motion as a complication of mitral valve repair, many investigators reported its postoperative incidence to range between 1 and 16% of mitral surgery patients. So we can see in this slide that it is most likely happening in association with hypertrophic cardiomyopathy. And the second in line post-mitral surgery, typically the mitral valve repair. Here we can see that the mitral valve consists of the anterior and posterior leaflets, the annulus and the subvalvular apparatus of the papillary muscles and chordae tendon. The function of the mitral valve depends on these structures, but also the global left ventricular structure and contractility changes in any element of this functional unit can predispose to or precipitate systolic anterior motion. In this slide, I can divide that systolic anterior motion could happen altogether, or if any of the geometric factors that can lead to SAM, kinetic factors, and structural anomalies. So the geometric factors included but not limited to annular undersizing, anterior displacement of mitral valve, and low anterior posterior length ratio, specifically below 1.3 in ratio to the posterior length, reduced mitro-aortic angle less than 15 degrees, distance reduction between mitral valve coaptation point and the septum. The kinetic factors, as we all know, the hyperdynamic of left ventricle either localized or generalized, can also contribute to lead to systolic anterior motion. The third part or third unit of the structural anomalies included redundant anterior leaflet, redundant posterior leaflet, papillary muscle displacement, bulging of the septum or cordial anomaly, or small left ventricular cavity. So here in this picture, I would like we can see in the left side, the normal heart, normal thickness of the left ventricle with nice coaptation point of the anterior and posterior mitral leaflets with papillary muscle attached with no deviation anteriorly towards the left ventricular outflow tract with open wide LVOT. In the right side, the heart with obstructive hypertrophic cardiomyopathy, we can see that the septum of the interventricular septum is hypertrophied, and that is causing stenotic to the LVOT, and with contribution of systolic anterior motion, and that can lead to a very devastating outcome for the patient. So here also we can see in early systole, the left ventricular outflow is open to the aorta. And let me tell you that the aortic root is even before beginning of the systole is more or less increased in size. That is due to pulsatility phenomena. And then at late or 2/3 of the systole, anterior motion of mitral valve most of the time will lead to the obstruction. And we can see here the obstruction, if it happened, it might or not be related also or associated with mitral regurgitation with varying severity. Here, in those coming slides, I would like to explain the role of the mitral leaflets, and then we will go to the role of the annulus of the mitral valve, and then the subvalvular apparatus of the mitral valve. In this slide, the role of mitral valve leaflets, let me tell you that excessive anterior or posterior leaflet tissue can predispose to SAM, because they provide a large surface area on which drag forces act, resulting from the high flow of blood through the LVOT, drawing the mitral valve anteriorly and towards the left ventricle, causing obstruction. They may also cause the mitral valve coaptation point to move anteriorly towards the left ventricular outflow tract. And let me tell you also, in any anatomical or surgical translocation of the mitral valve anteriorly will increase the forces acting to draw the mitral valve anteriorly, that may precipitate again to the SAM. And how such features actually result in SAM is not fully understood, but we will have some phenomena that could explain the mechanism of SAM happening. So the role of mitral leaflets, first is the Venturi effect. It was thought that Venturi effect, which is the fluid pressure reduction of areas of stenosis, like whenever there is a septum that is causing stenotic to the LVOT, and in addition to anterior motion of the mitral leaflet, and that area, it gets narrowed, and in narrowed area, the pressure gets really low, which can lead to a negative or low pressure gradient that can increase the velocity across that area, and in rule can deviate the whole mitral valve towards the ventricular septum. The second point is the elongation of, here we can see the proposed mechanism of SAM according to Venturi effect theory. We can see here ejecting flow in normal ventricle. We have a wide open track through the LVOT here with normal coaptation mitral valve. And here we can see that a high ejecting flow in SAM where where the stenotic area represent the Venturi effect, can draw the anterior mitral leaflet towards the interventricular septum, causing high gradient in the LVOT and might lead to obstruction. Here another proposed mechanism of systolic anterior motion according to engineering experimental model. Here we can see the clockwise normal flowing of blood from the mitral valve to the left ventricle and then to the LVOT. But this is a normal structural left ventricle and normal structure units of the mitral valve. In the systolic anterior motion, we can appreciate that whenever there is sloping out towards the anterior surface of the mitral valve leaflet, and also the area of posterior mitral valve wall got bigger, and then the flow got anti-clockwise, and that will also compromise the flow in the ventricle and the left ventricular outflow tract. The second role or phenomena is the elongation of the anterior leaflet. Could be a mechanism for systolic anterior motion. And this is supported by echocardiographic evidence, as Dr. May will explain thoroughly, showing that the anterior mitral leaflet height is an important predictor of systolic anterior motion. And this evidence provides the rationale for the anterior valvuloplasty as a surgical technique to address systolic anterior motion. And the third one is the changes to posterior leaflet height. Changes to posterior leaflet height have also been proposed to be important, as it results in anterior shifting of the coaptation point closer to the base of the anterior leaflet, predisposing to systolic anterior motion, and this supports the role of the sliding posterior leaflet plasty technique to move the coaptation point posteriorly. And let me tell you that there are many mitral valve repair technique for systolic anterior motion that can reach to 20 or even more surgical technique to tackle the systolic anterior motion. The fourth point is the anterior to posterior leaflet length ratio of less than 1.3 is an important ratio that we have to keep in mind and consider, as it give a high risk for systolic anterior motion. Here we can appreciate the difference during the systole of the angle between the aortic and mitral valve, and during diastole, and the difference between them. If it is less than 15 degrees, that is a high risk to develop systolic anterior motion, though there are many reports that even up to 21 degree can also be predisposed to systolic anterior motion. Here we can see some of the abnormalities that can happen that can lead to systolic anterior motion. Here we can see the normal morphology of the left heart side. Here we can see the long posterior leaflet that is pushing the anterior leaflet towards the interventricular septum. We can see also sometimes bulging of the septum, either in subaortic membrane or in the hypertrophied cardiomyopathy, that can also cause narrowing and then enroll the Venturi effect and the shifting of the whole mitral valve towards the septum. Here we can also see the papillary muscle deviation from the normal attachment site anteriorly, and that is unrolled, will deviate the whole mitral valve towards the septum. Here also the small artificial ring that is being applied like in surgery. If we apply a small size ring, that can also lead to sloping and shifting of the anterior mitral leaflet towards the interventricular septum. Now we move to the role of the mitral valve annulus. the insertion of rigid or semi-rigid mitral rings is associated with disruption of anterior mitral annulus dynamics. And this is always happening with rigid and semi-rigid, specifically if it is in a smaller size compared to the patient leaflet size or annulus size. The second point here is, let me tell you also, the annular undersizing is also a risk factor for systolic anterior motion, as it promotes bulging of the leaflet tissues. And this may occur when an excessively small annuloplasty ring is inserted, or if a misjudged posterior quadricular resection makes too much of the annular circumflex redundant. The second point is the annular undersizing. The annuloplasty ring sizes should be selected according to the risk of systolic anterior motion that is preoperatively planned with echocardiography revision if there is any risk factor or precipitating factors to systolic anterior motion. So with large rings used in patients at high risk of SAM is very advisable. The use of small rings is associated with postoperative SAM, as we mentioned, and their removal can resolve SAM sometimes. So any reduction in annular circumflex, this is the takeout, reduces the mitral aortic angle, which increases the risk of SAM. The third part is the subvalvular apparatus. The first is coaptation zone with respect to the septum. The subvalvular apparatus can alter the position of the coaptation zone, and then that can lead to SAM. The second point is the chordal anomaly, where there is a growing evidence that is associated with elongation and bulking of the chordae that can lead to SAM also. The surgical interventions on the chordae, including transection, translocation, and reimplantation, may result also in SAM in unexperienced hands. The papillary muscles are of special importance in asymmetric ventricular hypertrophy, where anterior and medial displacement of the papillary muscle significantly influence systolic anterior motion. Here we can see the normal attachment of the papillary muscle with a small small posterior wall of the mitral valve, and how it is co-opt, and if the posterior of the papillary muscle is attached more anteriorly anatomically, then there is a proposed of a phenomena that is a dragging force because of the first the deviation of the insertion site anteriorly, and second, because of the area of the posterior wall get bigger, then with ejection during systole, this might causes drag force that can even push the anterior mitral leaflet towards the interventricular septum, causing LVOT obstruction. Here we can start with the imaging modalities. Let me just introduce that traditional two-dimensional echocardiography is available at hand, easy to reach, and almost all the patients with valve surgery would have a preoperative echocardiography that can characterize them and can make those population who are at risk to develop systolic anterior motion to be taken care of. Also, we can use a pre-op transesophageal echocardiography or post-operative to also assess and judge the presence of systolic anterior motion. And of course, MRI, there are recent reports that is even more superior in terms of specification and give more knowledge towards whether there is risk to develop systolic anterior motion, or it can be diagnostic also for the patient who are non-surgical developed systolic anterior motion due to other causes or factors. And I think I would leave thorough explanation to Dr. May Shahid. Here are only few key points in regards of the imaging modalities. The risk assessment of systolic anterior motion. There are a number of structural and geometric factors for systolic anterior motion which should be assessed. The most important are the ratio of the anterior posterior leaflet height, the annular circumflex, and the distance between the coaptation point and the septum. Any systolic anterior motion at rest should be characterized and documented, including the LVOT gradient. So LVOT gradient is very important. A general assessment of the ventricle should be made as a geometric, including wall thickness, septal features, left ventricular outflow tract size, and any hypokinetic regions that can also precipitate or predispose to systolic anterior motion. Here is a question that is the SAM likely to result in clinically significant left ventricular outflow tract obstruction and or mitral regurgitation? I am concerned here regarding the diagnosis after mitral valve surgery. We can assess the severity to mild, moderate, severe, according to the, if we can say it's mild, if there is no LVOT obstruction, or there is negligible mitral regurgitation, then those patients most likely will respond to the medical management to correct any underlying metabolic pathology, or to give extra volume to expand the left ventricular filling pressure, and to discontinue inotropic drugs that can lead to hyperdynamic of the left ventricle and then make SAM worse. So if we address these things and it works and the SAM regress, then it is a medical management most of the time. If it does not, then we can always consider a surgical management as a definitive option. We can characterize it as a moderate if the pressure gradient over the LVOT is from 20 to 50 millimeter mercury, or up to moderate mitral regurgitation according to the echocardiography report, intraoperatively or postoperatively using transesophageal echocardiography. And then those might be considerably being tackled surgically, either by mitral valve and experienced hand, or if I'm not sure if the young surgeons should go in those situations to directly to replacement. I would leave that at the end of the discussion to the senior consultants who are around and senior residents and registrars that can comment on this. The severe one is whenever the left ventricular outflow tract is more than 50 millimeter mercury of gradient, or severe mitral regurgitation is identified, then the surgical management, either repair or replacement, should be considered. Here I am very happy to start hearing from Dr. May Shahid explaining to us the most crucial point in terms of echocardiographic findings and assessments and so on in regards of systolic anterior motion and hypertrophic cardiomyopathy.
Assalamu alaikum, everybody. My name is May Shahid. I'm an echo person in King Faisal Specialist Hospital and Research Center. I have to tell you how I got involved in this thing, and I hope Dr. Muhammad forgives me. I was sitting in my reading office, bi-aman Allah, when he comes in asking for one of our technologists who promised him to give him a list of our trifecta valves. So I've known Muhammad before when he did a rotation with us for almost a month in echocardiography, and I remembered him, and I only remember the people who give me a hard time, or the good people, and he was one of the good people. So I said, okay, let me ask him a question. Do you know what's so special about trifecta valve? And we'll leave this for another time. But something led to something, led to something, led to something. And all of a sudden, I find myself talking about Sam and Holcomb. So that's how he said, can you join us in our surgery? I said, I would love to. I love teaching, and it will be nice to hear from people after the talk. Unfortunately, he didn't tell me he was only talking about Sam. Otherwise, I would have got a case or two from our own OR. One case was severe and one case was mild. And he already touched on how the mild are managed. And most of the time, our cases are mild and they respond to decreasing the inotropes, to giving volume. Sometimes we give even beta blockers, short-acting like beta blockers, like to decrease the contraction of the ventricle, because all of these were involved. And usually it works, by the way. But I've seen a case or two where we had to replace the valve again. So most of my talk will be on hypertrophic cardiomyopathy and SAM, but it can apply to other conditions. And I want to stress something. I think it's very important for you as surgeons to know about SAM occurring after repair of mitral valve prolapse. And Muhammad has done very beautiful demonstrations for you. But we can see SAM almost every day in our service. So it doesn't have to be in Holcomb. We see it in intensive care units where the ventricles, you remember, these patients are old, most of them are old, they have hypertrophy because of hypertension. And being in intensive care, most of the time they might be not receiving enough fluids. So you have a hyperdynamic normal left ventricle, which is hypertrophied with hypertension, and where the patients are dry, so the ventricle is smaller. And we see many times obstruction inside the ventricle. We can get a gradient, sometimes very significant, or you can see even some. So it can happen with hypertension, it can happen with aortic stenosis, but definitely the classical milieu of it's in obstructive, in hypertrophic cardiomyopathy. And just to remind you, because now you're gonna be also operating on hypertrophic cardiomyopathy when there is obstruction and there is very marked thickening of the basal septum or other areas, which will not go into the details of it. But in Holcomb, we can have non-obstructive, we'll have obstructive at rest, or we can have labile, out of the blue, they get obstructed. And these are really difficult to deal with or even to prove. The latent obstruction, where you do provocative things, either in the echo lab or in the cath lab to do or to create the obstruction. And the most common thing we do is the Valsalva maneuver. And we will discuss this shortly. We can have mid-ventricular obstruction at the papillary muscle level, which are hypertrophied, and the classical apical obliteration in the non-obstructive apical hypertrophic cardiomyopathy that was first described in Japan, and which is characterized by marked T inversion. They are really humongous when you look at them. But of course, now it is described from all over the world. Echocardiography, like Muhammad said, especially transthoracic, plays a major role in establishing the diagnosis, in assessing the morphology and the extent of the hypertrophy, assess structural abnormalities. Is it the papillary muscle? Is it the anterior? Is it the posterior? Again, we can assess hemodynamic obstruction by measuring the gradient. We can assess the severity of the mitral regurgitation and time it. We can also assess diastolic function, because these are stiff ventricles that will contract normally, but their relaxation is very abnormal, so giving us diastolic dysfunction. And of course, we can define prognosis and guide the management. And to know what is abnormal, we have to be familiar with the normal. Forgive me if this is simple, but I want you to remember one thing. All of our echo pictures are like a triangle, or you want to call it a pyramid, but remember it's 2D, so I will call it like a triangle. And the tip of the triangle is where the probe is. And since we put the probe on the chest, and since the chest is anterior for always, this is anterior and this is posterior. So it is very important to remember this is anterior when we speak about the echo of SAM. The other thing I want you to notice is look how the leaflets are coapting, and they are coapting away from the septum. So it is systole. In systole, the aortic valve opens, the mitral valve closes, and it closes away from the septum, giving me a wide open left ventricular outflow tract. So I want you to remember these two things. The other things is the left ventricular function is assessed by looking at the short axis and by looking at the fourth chamber, which can again give you an idea about the severity of the hypertrophy. Where is it? Is it in the LVOT area, basal septum? Is it midventricular, or it is apical? The other thing is, again, I want you to remember is that the M mode, which a lot of people consider prehistoric, but I find it very helpful in many conditions, is what gives me the opening of the mitral valve in diastole and its closure. And I want you to notice that the closure brings the two leaflets together and they look like a straight line. So there are three things I want you to remember: that this is anterior, that the LVOT is open because the coaptation point is more posterior, and the M mode showing me a straight line here. So what can echo show you? It can show you what is the type of the hypertrophy. If you look at the short axis here, you can see that the posterior part, because this is anterior and this is posterior, you can see the posterior, or what we call by echo inferior wall, is thinner compared to the septum. And again, you can appreciate it here, and you can appreciate that there's no obstruction because I still have an opening reasonable. I would like it to be more open, but when you see SAM, you'll see that it will touch this more. We'll show it to you. This is a more striking non-obstructive. Look how thin, normal actually, posterior part of, or inferolateral or posterior, and look at the septum, how thick it is. And you can start seeing a little bit of SAM, but I will show you better examples. But the most important thing to notice that it is non-obstructive because my flow, in spite of having something here, but my flow into the LVOT is laminar. It is all red. It is not mosaic. Once you see an example of obstruction, you will understand what I mean. Now, this is the classical obstructive one. This is when it's playing, and you can see that there's something coming forward here. And I made a still picture for you to remember. This should be open. There should be nothing in here. I am in systole because my ECG will tell me I'm in systole and I have this obstructing my LVOT. So something have come into the left ventricular outflow tract, touching the septum and giving me the classical SAM. And this is what I mean by mosaic color, or a sign of obstruction, because I have this touching my septum. The blood, when it comes through this very, very, very tight LVOT, will be, the velocity will be accelerating, and it's no more laminar. It is very, very turbulent, and it gives me this turbulence into the LVOT. And then when you look at the left atrium, you can see I have at the same time mitral regurgitation. Remember the M mode, I will also show you another example. Remember I showed you that the M mode, there is a straight line here, which is away from the septum. The thing occurs in systole, so it's the end of the mitral valve opening, which is the beginning of systole till the next opening. And you can see that the leaflets are moving anteriorly into the LVOT, touching the septum, which is this structure, and causing the obstruction. So this is a classical M mode of SAM. We'll show it again in slow motion so that you'll appreciate it. And this is showing you the obstruction and the mitral regurgitation that occur together. And this is us doing the gradient. We go to the 5 chamber, we align with our flow, and we get a gradient. Here it is 69, which is very significant, but we did a Valsalva maneuver, and look what the gradient has become 116, which is severe obstruction. When we do Valsalva, we are increasing the pressure inside the chest. So it tends to cause, not obstruction, but cause sort of pressure on the very delicate pulmonary veins. So what I do with the Valsalva and the increased pressure intrathoracically, I am preventing through filling of the left side, or making the filling of the left side much less, making the ventricle smaller because it has not filled. And then by making the ventricle smaller, I make, like Muhammad explained to you, the obstruction bigger. So this is when I don't have significant, and I do, of course, this is significant, but when it is less here and I do a Valsalva, it gets better. This is a biventricular HOCM. It is in the left ventricle and in the right ventricle, and look how hypertrophied the right ventricle is. This is, again, you can see that there is hypertrophy, and I was going to ask you, is it obstructive? And it is not obstructive. Also, although I have hypertrophy, but this is open, and I only get a gradient with a velocity of 1, so the gradient is non-existent. And this is the classical apical hypertrophy. You see how echo helps in telling you exactly where everything. This usually I know is HOCM and not a thrombus, for example, because this part is contracting and this looks like a spade. I asked Muhammad whether he plays tarnib, and he says yes, because when we do contrast, you can clearly see the shape of the spade in this classical apical hypertrophy. So we show you by echo the magnitude of the hypertrophy and the site of the hypertrophy. And Muhammad has already explained to you how the anterior, most of the time, sometimes the posterior can move towards the septum into the LVOT tract towards the septum and cause the obstruction, and I can demonstrate it by M mode. But remember, as I already mentioned, it is not pathognomonic for HOCM. It can occur in the conditions I explained to you. And again, Dr. Muhammad has explained to you what are the things that make it more likely to happen: the long anterior leaflet, the long posterior leaflet, the position of the papillary muscle. And when we assess obstruction, we see how much the anterior valve has gone towards the septum. If you look here, I still have a little bit of space, but here has touched. So how much it moves towards the septum is important, and how much out of systole it keeps in touch with the septum. Look, this one is in touch for a long time. This is just a little bit, and compared to the normal here. So we assess how long of systole and how near it is to the septum. And this is a classical, beautiful SAM. And so that you can appreciate it, I made still pictures of it. Remember, in systole, I am at end of diastole, the mitral valve starts to close so that we move into systole, and it has moved backward as it should do. Again, it moved backward as it should do, and look what starts to happen. The anterior leaflet comes forward, it comes more forward, and then that's where the obstruction occurs. So you can see it in front of your eye if you play it slowly, that it went where it should be, and then the elongated anterior leaflet moved anteriorly into the LVOT and into the septum. Of course, continuous Doppler using the Bernoulli equation, I will not go into details, it will give me the gradient. And of course, we have to remember that the obstruction occurs with time. It doesn't occur immediately as systole occurs. It's a little bit later because it's dynamic, and this can be appreciated. You see how it is not immediately into systole, it waited to occur later towards systole. And this is beautiful to show you the acceleration and the mitral regurgitation occurring at the same time. And this is the systolic anterior motion, the mitral regurgitation, and the gradient, all of them of the same patient, showing us the degree of the thing. Now, the last thing I would like to mention is the mitral regurgitation, and it has occurred because the venturi occurred and it has pushed or pulled the anterior leaflet forward, preventing the coaptation of the two leaflets and causing the mitral regurgitation. I cannot finish speaking about this without mentioning diastolic dysfunction, because we have hypertrophy, we have what we call abnormal relaxation, but once this progresses, the filling pressure in the left atrium that is filling the left ventricle becomes high, and we move to a worse kind of diastolic dysfunction called restrictive cardiomyopathy. So there are risk factors for sudden death in cardiomyopathy. I think it's very important to remember that if somebody has been resuscitated or has VT or has significant family history of sudden death, this is a person who should not do well. And by echo, there are also features. If it is significant hypertrophy, more than 3 centimeters, normal is 1.1. LVOT gradient, which is very high, systolic dysfunction, markedly dilated left atrium. All of this will tell me that my hypertrophic cardiomyopathy is more severe. I hope that I have explained to you exactly by echo how the mechanism occurs, related the obstruction to the mitral regurgitation, showed you the different forms of hypertrophy, and I'll be sitting until Muhammad finishes his talk so that I can answer any of your queries. Thank you very much for inviting me to your meeting.
Well, massive thanks to you, Dr. May. I think this is a reference presentation about echocardiography findings in regards to SAM and obstructive cardiomyopathy from Dr. May Shahid. So as Dr. May Shahid mentioned, echocardiography has a central role in detecting systolic anterior motion and in characterizing the anatomical features of the mitral valve. Moving to the management of systolic anterior motion, I will not be late. I will touch only general rule of managing those patients who develop systolic anterior motion. First of all, the correct management of systolic anterior motion depends on 2 factors: the anatomical lesion responsible and the degree of severity of the finding, which is also related to the response of conservative therapy. So the medical management for those patients are three main things that we should consider to optimize them and to see their response to the medical therapy. First is to optimize the left ventricular filling, as thoroughly explained by Dr. May. We can consider discontinuation of diuretics because, as we know, most of the cardiac surgery patients are most of the time on diuretics. So this is a one step that we can take. Of course, if the patient or we have to ameliorate this or consider this as patient by patient according to the patient status. And also to give volume to fill that small, thick ventricle. But also in this regards, we have to first make sure that this patient does not have a very weak, dysfunctioned right ventricle. Otherwise, giving the volume might make the thing even worse because of severe right ventricle dysfunction. So consider those things whenever the patient status allows. The second is to maintain slow sinus rhythm. And I've been searching if there is any target of the rate, or I think the best rate that we can reach is the sinus rhythm of 60 beats per minute to allow and help a stiff ventricle and to lessen the systolic anterior motion. This is one. Second of all is to decrease left ventricular contractility by discontinuation of inotropes that can make the ventricle more contractile. And we can also consider beta blockers if there is no contraindications to reach the target of sinus rhythm of best of the time is 60 beats per minute. And increasing after load, utilizing vasopressin, phenylephrine, norepinephrine. And this is a rule, again, will for best of my knowledge, that this gonna help pushing the whole mitral valve units more posteriorly by elevating the systemic vascular resistance. Those are the three main things that we can consider as a medical management, and we see the patient, how they act, how they respond, and then we can judge whether those patients are in risk of late failure. Then we have to consider a definitive surgical intervention. Here, I want to present to you one very interesting article that's been published in 2007. The question is, what is the role of medical therapy? So this is an article published in Journal of Cardiothoracic Surgery in 2007, which retrospectively assessed the effectiveness of medical therapy in all 174 cases of SAM arising in a cohort of 2,076 patients after mitral valve repair, and that is in total 8.4% in whom developed systolic anterior motion. So they report that the treatment with beta adrenoreceptor blockade, volume loading, and phenylephrine was sufficient to correct systolic anterior motion in the vast majority of patients, and only for patients required reoperation for systolic anterior motion. And at late follow-up, SAM persisted in only 17 patients out of 174 developed SAM out of 2,076 patients. These results suggest to me that medical therapy alone may be sufficient for mild systolic anterior motion, but always surgical therapy remains the definitive therapy for serious systolic anterior motion in an experienced center and, of course, an experienced hand. So the last part is the surgical management. This is another talk for another full time by hopefully one of the senior consultants to touch on the mitral valve. Let me tell you that in hypertrophied obstructive cardiomyopathy, septal myectomy is most of the time indicated to relieve the LVOT obstruction. Second of all, in cases of systolic anterior motion with no obstructive cardiomyopathy, mitral valve repair versus replacement, or altogether both in the same setting can be considered. And this is according to the patient perioperative planning and what is the best for our patients. Finally, take out from whatever I have read, I have discussed, and I have get out of the revision of this topic. Systolic anterior motion of the mitral valve can be a life-threatening condition, so we should really pay attention to it. The systolic anterior motion can result in severe left ventricular outflow tract obstruction and or mitral regurgitation is always considerably associated with an up to 20% risk of sudden death. The mechanisms of systolic anterior motion are complex and depend on the functional status of the ventricle, as we mentioned before, the 3 units of the mitral valve, the leaflets, annulus, and the subvalvular apparatus. The systolic anterior motion can occur in the normal population, but is typically observed in patients with hypertrophied cardiomyopathy, not necessarily obstructive cardiomyopathy, or following mitral valve repair. Echocardiography, 2D, 3D, and stress echocardiography as a provocation study has a central diagnostic role, as thoroughly explained by the respected Dr. Mahesh Shahid. Systolic anterior motion predictors, as also explained, allows the incorporation of prevention techniques during surgery and post-operative systolic anterior motion assessment. Thank you for your patient hearing. I hope you enjoyed our talk, especially Dr. Mahesh Shahid slides. Here we are. We can end up our session and topic of systolic anterior motion by questions and comments if you would like. Please, either you want to, whoever have question or comment, to go ahead.
Thank you, Dr. Muhammad. Thank you, Dr. Amay. Anyone have any questions or comment, please?
Dr. Amay.
Okay.
This is Ayat. Thank you for this nice slides. Just one question regarding the gradient, the picture that you showed, the shape of the image that shows the gradient. Can you get back to it, Muhammad? The one with Valsalva maneuver.
قبل شوي. Come on. Okay, we have 2 of them together. Come on. Okay, here you are.
Yes, this one. So I've read that it's dagger shaped like it shows like this. This is yani special for Holcomb. So this happens because of the late filling or what? Why it's happening, this shape?
Remember, yeah, okay. Remember that the obstruction occurs because the anterior leaflet is moving forward in systole. So during systole, the ventricle has to get smaller because it is ejecting the blood out of it. So it is only, remember, it is also a hypertrophic left ventricle. So it has to get together. The 2 walls or the walls of the left ventricle have to get together for the obstruction to occur. And this occurs later in systole. We call it dynamic obstruction. We see it in intraventricular hypertrophy within the papillary muscle level and later on, because it occurs later in systole after the anterior leaflet has moved. That's why it is late, dagger-shaped, and dynamic. Does this answer you?
Yeah, thank you so much.
وكيفك آيات? I hope you are fine.
الحمد لله حبيبتي الحمد لله.
Well, I think there is no more questions. I hope this is because everybody has enjoyed the topic, and the topic has been explained very well. Thank you, Dr. May, for coming, for giving us from your precious time and precious knowledge that we always keen to learn from you, specifically in the field of echocardiography.
Thank you yourself for inviting me. Best of luck to all of you guys.
Thank you, Doctor. Thank you, Mohammed.
Thank you.
Thank you, Dr. Mohammed. Thank you, Dr. May, for this lecture. We will have a break for 10 minutes, then we'll start the next lecture. حياة حياة
دقيقة يا مهند. Okay, you hear me now?
Yes.
Okay, so good afternoon, everyone. I'm gonna talk today about hypertrophic cardiomyopathy. My lecture was supervised by Prof. Zuhair Al-Hadis, and he provided me with some resources. Okay. So these are my references, Johns Hopkins and Consari for some surgical pitfalls, and also some echo findings from pediatric cardiology booklets, also TESTRA clinical scenarios, and the HA 2020 guidelines. So as an introduction, left ventricular hypertrophy in the absence of an underlying cause such as systemic hypertension or valvular aortic stenosis is a definition for hypertrophic cardiomyopathy, the idiopathic one. The prevalence is 0.2, which is 1 in 500 for asymptomatic patients, and it's less than 1 in 3,000 in symptomatic individuals. LVOT obstruction is caused by septal hypertrophy combined with the systolic anterior motion of the mitral valve, and this in turn produces variable degrees of mitral valve regurg, and the obstruction occurs in 70% of hypertrophic cardiomyopathy patients. The subaortic membrane differs from the LVOT obstruction in hypertrophic cardiomyopathy, that in LVOT obstruction usually we have systolic anterior motion, and this just to clarify the difference. This is a picture for the morphology of hypertrophic cardiomyopathy. So it might be apical, it might be diffuse, it might be in the basal septum only, and so this can be differentiated on echo usually, as Dr. Amay mentioned before and explained. So do phenotype, morphology of the hypertrophic cardiomyopathy, severity of hypertrophy correlate with genotype? No, it's not. So usually we investigate people with hypertrophic cardiomyopathy, and we do genetic analysis sometimes just to figure out if there is anyone in the family has the same disease. So they are from the same family, but they have different genotypes. So it doesn't correlate almost all the time. The mitral valve in this disease, so the anterior leaflet moves anteriorly during systole, as explained by Muhammad, and the posterior leaflet closes against the mid and the free edge third of the anterior leaflet instead of the free edge as occur normally. The free edge of the anterior leaflet is then displaced upward and narrows the LVOT tract, and the anterior displacement of the valve leaflets produces MR of variable degree. And the direction of the jet produced by this MR is posterior lateral, not central. So if it is central, means that there is a disease in the mitral valve itself, unlike the SAM here. The characters of HOCM, that MR, it's important pathophysiologic component of HOCM and contributes to the symptoms like dyspnea and fatigability, and opposition of the anterior leaflet to the bulging septum produces a contact lesion, which is a whitish endocardial scar that is useful in guiding the septal myectomy that we are going to talk about. As Dr. Amay mentioned, that there are different provocative maneuvers that elicit the latent HOCM. So occurrence of SAM in HOCM is often dynamic, and the maneuvers will elicit this. Like, for example, standing, Valsalva maneuver, and also even the effort of respiration also will elicit the SAM and HOCM. Also some medications they give. So it's it's dynamic disease. The associated anomalies of HOCM. First, we'll talk about papillary muscles. So they are abnormal in 15 to 20% of the patients. Usually they have anomalous papillary muscles. There is, for example, direct insertion of papillary muscles into the anterior mitral valve leaflet, and this is the most common one. Also, we might have fusion of the papillary muscle to the ventricular septum or LV free wall. Also, accessory muscles and accessory anomalous chordae, which is called false chords. And a question: do those anomalies contribute to obstruction or complicate the myectomy? So usually no, but if it is, for example, as mentioned here, if the papillary muscle interfere, for example, with the anterior leaflet, then there is an abnormality of the mitral valve itself, so we have to intervene. But usually not, it doesn't complicate. For the coronary arteries, so decreased flow reserve is associated with a reduction of coronary resistance. So the compression that comes from HOCM, it's not the issue. The issue is the decreased flow reserve of the coronaries. So in hypertrophic cardiomyopathy, the maximal vasodilatation in the microcirculation and of the basal status of the coronary will be the issue, not the compression. They are abnormal coronary artery in 5 to 15% of the patients. They are severe in 26%. And if we have a patient with hypertrophic cardiomyopathy with coronary artery disease, then the survival of the patient or the prognosis of the patient will be poor than a one without a coronary artery disease. Also, if the ventricular function was affected, then it's also more severe. So those things has to be taken into consideration. We have LAD bridging. It happens in 15% of the patients, and in adults, it's the cause of sudden cardiac death. And for children, the chest pain, the cardiac arrest, with subsequent resuscitation or VTAC and MI, they are more in children. And hypertrophic cardiomyopathy with MI has a poor outcome, of course. Going to the histopathology, so myocardial fiber disarray, which consists of short runs of severely hypertrophied fibers interspersed by connective tissue, and the myocytes show large bizarre nuclei with degenerating muscle fibers and fibrosis. And then the myocardial fiber disarray, this is not a pathognomic feature of hypertrophic cardiomyopathy. Anything with or any disease with the pressure overload might show this. So it's not special for hypertrophic cardiomyopathy. Moving to genetics, so the clinical value of genetic testing is uncertain, and approximately 60 to 80% of cases are familial, and the remainder results from de novo mutations. It involves the sarcomeric and non-sarcomeric proteins, and over 400 mutations and over 15 genes have been identified also. We have multiple protein encoding genes like beta myosin heavy chain. It's in 35 to 50% of the patients. And then we have myosin binding protein C, 15 to 25% of the patients, and also cardiac troponin T type 2. This is a table showing the guidelines for genetic analysis. I know it's not clear, but what I've read that genetic analysis is not necessary, but when I went to the guidelines, it seems that it's really important up to 3 generations in the family that you have to investigate and do genetic analysis for them. So usually it's more important in patients who had history of sudden cardiac death, especially from first relatives, or for example, they're having high risk issues. But from the guidelines, it's also for other patients or for patients that you, for example, suspect another genetic disorder. So you have to think about it. Moving to the pathophysiology of the disease, so we have multiple issues in this disease. So diastolic dysfunction with elevation of LV and diastolic pressure is the principal pathophysiologic feature in this disease. And then increase in the left atrial and pulmonary venous pressures. And then with worsening diastolic function, the LV filling becomes more dependent on the atrial contraction, and occurrence of atrial arrhythmias such as atrial fib can cause acute and profound decrease in cardiac output and worsening of the symptoms. Then LVOT obstruction has a direct effect of increasing the LV and diastolic pressure, and indirect effect on the hemodynamics through the often associated MR. And then we might have chordae rupture and leaflet prolapse contribute to heart failure, and also the hypertrophic cardiomyopathy might be worsened if not recognized and treated medically in early stages, especially if patients are having patients with atrial fibrillation. You have to recognize them and start them early on DOAC so that you prevent thromboembolism. Also, we have MI as a part of the disease, and also autonomic dysfunction. So impaired heart rate recovery, inappropriate vasodilatation, abnormal blood pressure, all are autonomic dysfunction in such a disease. With abnormal blood pressure response in 25% of the patients, this gives poor prognosis. And then we have, I'm going to talk about natural history. So the clinical course of hypertrophic cardiomyopathy is variable, and the onset of symptoms is often associated with the development of LVOT obstruction. And the adverse events develop in 30 to 40% of the patients. And it's uncertain what causes this in adults. So we don't know why they have no gradient till the 4th, 5th, or 6th decade of life in some patients. The onset of atrial fib can also precipitate symptoms predisposed to systemic embolism. It occurs in 6% of patients, and it's noted in 30% of older patients with this disease. And we have mentioned that it's important to start them on anticoagulants. And then infective endocarditis may occur also with this disease, with an incidence of 1.4 cases per 1,000 persons per year. And it increases with patients having obstruction. The survival of patients with this disease is similar to individuals without the disease, and the mortality is less than 1% if you intervene early. And then it's the most common cause of sudden death among young athletes, and we have seen, I think, a lot recently. For obstruction versus none, there is a strong correlation between resting outflow gradients and the late risk of death. And patients with obstruction with a basal gradient of at least 30 Hg had a risk of death from the disease or symptoms of progression that was more than 4 times than observed among the patients without obstruction. So they have, poorer prognosis than the one without obstruction. Patients with obstruction and mild symptoms like NIHA class 2 were more likely to have progression to severe symptoms or die from heart failure than asymptomatic patients with cardiomyopathy. Moving to diagnosis. So to start with, you have to take a good history from the patient. Emphasize on family history and so on, and then you examine the patient as usual, and then you start your investigations. So first of all, for basics, you start with ECG. It's abnormal in 75 to 95% of the patients, and it will show things that are not specific, but you might see them, like LV strain pattern, Q waves, and giant negative T waves, and lead V4 to V6. For echo, I think Dr. Amay Shahid has explained, and of course she's better than me, but I'm gonna just review it quickly. So we start with 2D echo. It will show you the ventricular morphology, the hemodynamics, the valve function, and the structures. So it might be concentric hypertrophy, it might be localized segmental hypertrophy. It will show you the asymmetry of the septum, and then you might suspect apical hypertrophic cardiomyopathy, and it might be missed. That's why if you suspect it, you have to do, or if it is inconclusive, you can do a cardiac MRI. This is the short axis showing the different distribution, different patterns of distribution of the hypertrophy. It might be apical, it might be diffuse, it might be in the anterior wall only. So it differs regarding the morphology on echo. So morphology of the septum appear to vary according to age, and older patients with this disease often demonstrate a sigmoid configuration, just to keep in mind. So we have a diastolic LV wall thickness of 15 millimeter, or on occasion 13 to 14. Also, usually LV dimensions are less than 45. This is acceptable to diagnose this disease in adults. And the heart of some highly trained athletes may show hypertrophy of the LV wall, making it difficult to differentiate between the hypertrophy that the athletes have and the disease, the hypertrophic cardiomyopathy. But LV wall thickness of 13 or greater is very uncommon in highly trained athletes. And also, it's always associated with enlarged LV cavity with LV diastolic dimensions of more than 54, ranging from 55 to 63. So this is just to differentiate. You will see asymmetrical septal hypertrophy of the interventricular septum with the septal thickness of 1.4 or 1.5 times greater than the posterior LV wall, and occasionally some of the anterior mitral leaflet in the obstructive type. The average maximal LV wall thickness is 20 to 22 mm, and in 5 to 10% of the patients, LV wall thickness is dramatically increased, measuring 30 to 50 mm. This is a picture showing, I think, the same as Dr. May showed. So this is the apex, and you can see the LV posterior wall and the septum. So the septum is 1.5 hypertrophied than the LV posterior wall. And this is how it looks like on echo. The Doppler peak gradient in the LVOT of 30 mmHg indicates obstructive type, and this will show as high velocity, late peaking, dagger-shaped signal. As we have discussed with Dr. May, it's like this, dagger-shaped. And then the MR that results from SAM is eccentric and directed posterolaterally during late systole, as we mentioned earlier. But a centrally directed jet will raise the suspicion of primary leaflet abnormality, as we mentioned earlier also. So keep in mind, okay, echo findings will give you clues about the disease, but also increased wall thickness might has other causes, including systemic hypertension, especially in dialysis patients, and then valvular aortic stenosis, also infiltrative and glycogen storage disease, such as amyloidosis and Fabry's disease. So keep them in mind. The patient might have other than HOCM. In patients with low velocity at rest less than 3 milli per second, so maneuvers such as Valsalva or inhalation of amyl nitrate or exercise may demonstrate the latent obstruction. As we mentioned earlier, it's dynamic disease. And for the TEE, the guidelines mentions that we don't usually do TEE unless the transthoracic echo is inconclusive, or if you are operating on the patient. So if the patient fit for surgery, then you have to do, for example, pre-op TEE just to show the pattern and to show the different characters that we have mentioned earlier, and also to make sure that the mitral valve is okay. So if you are suspecting something abnormal in the mitral, and maybe it's not only SAM, but also some other diseases like excessive tissue or something. So just to keep your just to plan your approach, I mean, and your plan for the surgery. For the cardiac MRI, so the recommendations, you don't usually do cardiac MR unless the echo is not conclusive, okay? Or, for example, you are suspecting alternative diagnosis, or you are suspecting that there is apical hypertrophy, or, for example, apical aneurysm, and so on. So usually we don't do it unless we suspect something. Okay, for to be level of evidence 2B, then for patients with the hypertrophic cardiomyopathy, you repeat the contrast enhanced cardiac MRI imaging on a periodic basis of 3 to 5 years for the purpose of the sudden cardiac risk stratification. Okay, to evaluate the morphologic changes, the ejection fraction, the apical aneurysm, the LV wall thickness, and so on. And then we move to the cardiac cath. So it's not necessary for all patients, but if you are having inconclusive study, or you wanna know more about hemodynamics, you wanna invasive hemodynamics assessment, then you do cardiac cath. Or if you are suspecting that the patient is having evidence of myocardial ischemia, or also for elderly patients that you suspect that they are having coronary atherosclerosis, then you do cardiac cath prior to surgery. For the cardiac CT, so CT, you do it if for example, echo is not diagnostic or the MRI is not available, and if you are suspecting that the patient is having anomalous coronary artery, for example. So you do CT just to see those anomalies, and also it will show you the function of the heart, it will show you the LV wall thickness, and so on. So when we talk about management of such a disease, so we have to have a multidisciplinary approach. So I believe that this disease has to be an experience center as recommended in the guidelines, and it should be the case of HOCM should be presented to different teams, so you can take a decision if the patient is going, for example, for medical versus surgical or interventional. So you refer the patient to a comprehensive, for a comprehensive discussion. You don't just discuss them with a small team, for example. So I believe in multidisciplinary team actually. Moving to the treatment. So treatment, we can divide the plan or the treatment into 3 categories. So we have medical, we have interventional, and we have the surgical approach. For the medical, you have to decrease the cardiac contractility to relieve the obstruction, and you have to slow the heart rate to enhance diastolic filling. So whenever you have a patient with hypertrophic cardiomyopathy that doesn't need surgery immediately, then you start them with medical therapy, and these are the medications. So you start them as class 1 with beta blockers, okay? And it's successful up to 80% of the patient. They it relieves their symptoms. And then if the patients did not tolerate beta blockers, or they have, for example, ineffective treatment with beta blockers, then you start them on calcium channel blockers like verapamil or diltiazem. It's recommended. And then if they didn't tolerate those, or symptoms still persistent and they have severe symptoms from the obstruction, then you start them on disopyramide, which is a sodium channel blocker type 1 antiarrhythmic drug. And then you consider also septal reduction therapy, whatever, the surgical or the interventional. And then the diuretics are not recommended unless the patient needs it. Okay. Starting with a low dose, of course. Okay. So to keep in mind that there is no difference in sudden death mortality between patients on beta blockers, amiodarone, verapamil, or sutalol. So no difference compared with patients who were not on pharmacological therapy. And this is what I've read. So they need ICD, and we'll talk about ICD indications in a while. Before that, you have to discuss the lifestyle with your patient. So it's recommended that you discuss the sport, the activity, and if a female is planning to get pregnant, and if the patient is having comorbidities, then you have to put a plan to modify those comorbidities. So it's not only about the disease, it's also about the patient. What fits for them, I mean. For the ICD, so it's one of the things to do to prevent severe symptoms from happening or sudden cardiac death, for example. So the indications are from the guidelines. If you have a prior event of sudden cardiac death or VF or sustained VTAC, then it's a class 1 to put an ICD for the patient. If no, then at least one of the following, if there is a family history of sudden cardiac death, if there is a massive LVH, if there is an explained syncope, apical aneurysm, ejection fraction less than 50%. If yes, then ICD is reasonable. If no, then you go, you assess more. If you have non-sustained VTAC, if yes, you go for the ICD, which is reasonable 2A, class 2A. If no, then you do cardiac MRI. If there is a late gadolinium enhancement on cardiac MRI, then ICD may be considered, it's 2B. If no, then ICD is not indicated and it's harmful for the patient. This is from the American Heart Association 2020 guidelines. Also, I've read from the book that hypotensive response to exercise is an indication for ICD insertion, and then findings of myocardial bridging in young patients or myocardial fibrosis detected on MRI may also increase the risk of sudden cardiac death, so you have to put for them an ICD. For the dual chamber pacemaker, it's controversial, and the long-term clinical benefits have not been consistently beneficial. And they mentioned that if you pace the RV, it will relieve their symptoms and the gradient and so on, but it's controversial. Okay, so you delay the device implantation. It's preferable until the third or fourth day post-op, and you avoid and take attention or pay attention to lead dislocation if the ICD is placed immediately pre-op. Moving to the surgical treatment, so it's reserved for patients who continue to have limiting symptoms despite medical treatment, and if they have septal thickness of more than 30 with increased risk of sudden cardiac death, or long-standing LVOT obstruction leading to heart failure. These are the recommendations. So as we have mentioned, if we have severe progressive pulmonary hypertension that attributes to LVOT obstruction, if we have left atrial enlargement more than one with episodes of atrial fib, poor functional capacity, and children and young adults with very high resting LVOT gradients. So these are some criteria that necessitate surgical myectomy in a comprehensive centers. Okay, after discussion with the team, of course. Okay, so starting with the surgery, you do before that pre-op TE, as we mentioned earlier. You assess the mitral valve, you assess the hypertrophy, you assess the function and everything. And then you start the surgery, but the approach, we have different approaches. So the most common one is the transaortic, and some surgeons will do ventriculotomy, okay, just to expose the apical hypertrophy and resect the muscle there, but they don't do it usually. And there is also another approach that if you have inadequate exposure, then you can do left atriotomy, okay, and from there you expose the hypertrophied muscle very well. Okay, so with the usual opening, median sternotomy and the usual opening you start with, and then you cannulate, you cool the patient into moderate hypothermia, and you pay attention to the cardioplegia. So usually the hypertrophied muscle needs attention more than the normal heart. So to protect the heart, you give antegrade and retrograde cardioplegia to protect. And then here is a picture. So you open the you did your aortotomy. Aortotomy is low into the non-coronary sinus. Okay, it's low there, and then you expose. You put a retractor to help, and there are other methods to expose. I will put some pictures. I have them. And then with an 11 blade, you resect between nadir to nadir of the right and left coronary cusps. Okay, you resect. It's below. It's a 3 mm below the annulus, and from nadir to nadir, and you extend up to 7 cm until you see the anterior papillary muscle of the mitral valve. And as you see here, it's in the middle of the leaflet here. The blade, I mean, the position. This is another picture. This is how we resect. And we have a risk that we might, particles of the resected muscle might go into the LV and causing embolism. So we are going to talk about this in a while. This is another picture. I meant by the exposure to put a suture with the bludgeons. So for more exposure, and then you have the retractor, and the assistant will help also just to expose the area. Here's a picture showing the extent of the resection. So you resect until you see the anterior papillary muscle of the mitral valve. Okay. And here, just a clue to prevent the fall of the particles or the resected muscle, that you can put a fluoroproline, for example, and retract the muscle that you are going to resect with. It might be with a bludgeon or without a bludgeon. Okay, and then after finishing, you close the aortotomy and you prepare the defibrillator beside you, because you might have a ectopi. Okay, so you have to have a defibrillator beside you. And then you wean off bypass, but you keep your cannulas. So after seeing the echo and so on, then after that you assess and you decannulate. For the post-op TE, the gradients more than 10 to 15 mmHg, and I've heard from Dr. Khagir that if it is more than 20, then you review your resection. Otherwise, if there is some, for example, you keep the patient volume loaded, and you stop the introbes, and you assess before just jumping into reviewing your resection. If you are happy with that, then you decannulate and close. About the mitral valve, so the SAM, as we have mentioned earlier, it's gonna be relieved with the resection and also with the medical management. But if it is still persistent, then, or you are suspecting, for example, that there is abnormality of the mitral valve, then you have to intervene during the surgery. So you can repair and preserve replacement for patients who failed the repair. So you repair, for example, with Alfieri stitch, you repair with plication of the anterior or posterior or anterior or posterior leaflets, and you put annuloplasty for them just to relieve the sound. For the alcohol ablation, so the alcohol ablation is an intervention where you inject alcohol into the septal perforators of the LAD, and you create a necrotic tissue just to get this hypertrophy to make it less, so it will be regressed with this necrosis. I've read about this, and I was convinced that I'm not sure, but I was convinced that alcohol ablation is not gonna work, because I've read that multiple issues might happen, unlike the surgery. So I've read that the scar that they create is gonna be an arrhythmogenic focus, so patients will suffer from arrhythmia. And also the alcohol that they inject, it might go into the LAD, the dissection might happen, and multiple things, and tamponade and everything. So I searched about that, and I found that an article saying that there were no difference in survival of patients undergoing myectomy or alcohol ablation, but freedom from re-intervention and early and late reduction of LV outflow tract gradient are superior in patients undergoing septal myectomy. And you can comment on that, guys, at the end of the lecture. So I was convinced more with the surgery, but again, I will be biased because I'm a junior still. I'm not experienced in this. Moving to the heart transplants, so the guidelines saying that for class 1 in patients with hypertrophic cardiomyopathy, recurrent poorly tolerated life-threatening ventricular tachyarrhythmia, refractory or maximal anti-arrhythmic drug therapy, also ablation, you have tried it and then you failed. So heart transplant assessment is indicated, and you list them for transplants. Also in adults with hypertrophic cardiomyopathy and symptomatic ventricular arrhythmia, recurrent ICD shock, despite beta blockers or antiarrhythmic drug. So you list them for heart transplant. Okay. So it's reserved for patients that are refractory for all the treatment modalities, I mean. Moving to surgical complications, so we have here, as you can see, that when they follow 69 patients with 3.7 plus minus 2.4 follow-up years, they found that there is a zero insertion of a pacemaker, unlike the alcohol ablation. And then the VSD was 2.9%, AI was 0, and then the MR was 0, and the reoperation was 0, unlike alcohol ablation. So I believe that we keep it for patients with comorbidities, not all the patients. For the outcome and the prognosis, so early mortality is 0 to 6%, And the surgical risk might be higher among very elderly patients, particularly those with severe disabling symptoms associated with pulmonary hypertension, or patients with prior myectomy, or those requiring concomitant procedures. The late mortality is less than 10%, and the 5 years survival is 84%. And then for 10 to 15 years survival, we have 80 and 72%. For the 20 years survival, it's 53, and the average yearly mortality is 1.3%. And thank you. This is me in the OR, happy like if I own the world. Thank you so much for listening, and I'm happy to receive questions or comments. Dr. Khadir, are you there?
Yes, I'm here.
Thank you for attending.
Sure. Very nice presentation.
Thank you so much. Do you have any comment, any question?
For those who are interested in hypertrophic cardiomyopathy and how to handle it, it's been recommended that you should only operate on those patients where you have a center of excellence. Yeah. And there are quite a bit of criteria have been written about this. In the US, there are only 16 centers that are considered as centers of excellence for treating this disease. And they do have quite a bit of experience. In our hands here, over the last 40 years or so, in King Faisal, we have accumulated somewhere in the range of 40 to 50 cases. So it's not very common, or we don't get the referrer enough for the population. There are certain areas where this disease seems to come or concentrated in families in certain areas of the kingdom, which once you get acquainted with, you start really looking at the families, and just like Ayat said, you really have to examine the whole family. Somewhere around 50% of those patients have familial and genetic predilection for this disease. Thank you, Ayat.
Doctor, what about alcohol ablation? Do you believe in that?
It's not a matter of personal beliefs. We had a visitor in a grand round about 3 years back, who I think came from Boston, and it was interesting to see that their data is showing a comparable success rate. Now, in the guidelines, you probably find out that there are certain groups of patients. For example, it should not be operated on younger population, 20 years or younger. And the main reason there is because of the long-term expectancy of and the complication rate that can happen. It's also advisable not to do this procedure for younger than 40s. And this is most of our patients actually in that group. The long-term, with good medical treatment, with good change in lifestyle, the numbers you have mentioned about mortality, including the operative mortality and the annual mortality of this disease, have really dropped significantly in those centers of excellence. I believe it's somewhere around 1.8% of incidence of sudden death, for example, even with severe disease. So, but once it happens, once the patient is symptomatic, then it's a different story. And the results of surgery is very good. One of the techniques that we use, I personally like very much, is called the Moro's technique. Yeah. And basically what you're doing is definitely cutting a corridor across the septum all the way until you see not only just the attachment of the anterior leaflet, but you also visualize the apex of the left ventricle. And that have given us very good results. other complicating factors, older age, coronary artery disease, mitral valve pathology, which may be associated or may be part of the disease of Holcomb, but also it could be a separate pathology, like the disease, the mitral valve apparatus may be different or diseased. So those things can change the prognosis dramatically.
Yeah.
Thank you again.
Thank you, doctor. Any question from colleagues?
Thank you, Ayat.
Thank you. So thank you for listening. I will unshare.
May I say something? There is a very nice book. It's about 400 pages or so. It talks specifically about cardiomyopathy, not obstructive, but the hypertrophic cardiomyopathy. And I think it's a very good reference for those who are interested in this disease. If you wish, I will send this to Ayat, and she can distribute it to those who are interested.
Yeah, sure. Thank you so much, Doc. Thank you all.
Okay, thank you, Ayat, for this presentation, and thank you, Dr. Farid. So we'll have a quick 10-minute break, and we'll come back for the journal club. Dr. Abdulrahman.
Assalamu alaikum.
Assalamu rahmatullah.
Shall we start it?
Yes, I'm not sure Dr. Abdullah does. No.
Yeah, he is.
So I would like to welcome Dr. Abdullah Ataybi, who's a consultant cardiac surgeon at Saud al-Batin Cardiac Center in Dammam. Thank you, Dr. Abdullah, for joining us. Can start, Abdulrahman. Thank you.
Okay. So, yeah. Today, our journal club will talk about the partner trial. So the partner trials was talking about the patients with severe aortic stenosis and coexisting factors that made them not a good candidate for the surgical replacement. So the TAVI, or the transcatheter aortic valve implantation, has been suggested as a less invasive treatment for the high-risk patients with severe aortic stenosis. So that's when the partner trial 1 started and showed that patients with severe aortic stenosis who were not a good candidate for surgery, TAVI was compared with the standard therapy and showed that significantly reduced the rate of death from any cause and composite endpoint of death from any cause or repeat hospitalization, cardiac symptoms despite the higher incidence of major stroke and major vascular events. So after the partner trial 1, we'll talk about the partner trial 2, which is comparing the TAVR with the surgical replacement in patients with severe aortic stenosis and an intermediate risk factors. So partner trial 2, they collected 2,000 patients from many centers in the US and Canada. Patients were considered to be at intermediate risk, SCS of 4 to 8. The primary endpoint was death from any cause or disabling stroke at 2 years. The primary hypothesis was that TAVR would not be inferior or to the surgical replacement. So here,
Abdulrahman?
Hello.
Okay.
Yes.
What does it mean non-inferior? Randomized controlled trial. What does that tell you?
That the TAVR is equal to the surgical replacement and the intermediate risk factors patients.
When you're planning an RCT, there is a superiority RCTs and a non-inferiority RCT. Do you know the difference? And when would you use one over the other?
Actually, I don't think so. I'm not sure.
Anybody from the audience know? Anybody from the residents? Should we proceed? typically, when you plan an RCT, it should be a superiority trial, because you're going to prove an intervention is superior to a placebo, for example.
Yeah.
Or there is a treatment that's not optimum, and you invented a new treatment that you want to prove it's superior to the currently used treatment. You usually go to non-inferiority design if the current treatment is the standard, or you cannot use a placebo. We know patient with symptomatic aortic stenosis, the treatment is surgical AVR. And you cannot deny it to the patient, but you offer them an alternative way of doing it, which is TAVI, is that, and then you prove that the TAVI is not inferior to it. Is that clear?
Yes.
Okay. You can proceed.
Okay, thank you. So here's the schedule showing the characteristics of the patients were well balanced between the two groups, with the mean STS score was 5.8.
Go back. Look at the age.
Yeah, the mean age was 81.
And
between
look at
the two
sex.
groups.
Look at the sex.
Yeah, male was more than the females.
So no, it was almost 50-50.
Yeah.
Because the reason I highlight this just to compare it to the low risk one.
Yeah.
Okay.
Yes.
Okay. Go ahead.
So the results, there was no significant difference in the primary endpoint of death from any cause or disabling stroke at 2 years between the TAVR and the surgery group. The interesting thing that in the transfemoral axis cohort, the TAVR resulted in a lower rate of death from any cause or disabling stroke than did the surgery.
Okay, go back.
Yeah.
Do you know what are these graphs? What we call them?
I'm not getting the question. What?
What you see is a graph. Is that correct?
Yeah.
Right?
Yes. Yeah.
What do you call this graph? Does it have a name?
I'm not sure.
Anybody from the audience know?
Is it Kaplan-Meier?
Yes. We have to know. Okay. And then it represents with the hazard ratio. What does a hazard ratio mean?
The hazard ratio?
Yeah. A hazard of 1, what does it mean?
I think it means both are equal.
Yes. And if a hazard is less than 1?
The new modality of treatment is safer.
Exactly. And when you look at the confidence interval, once it crossed 1, what does that mean?
If it crosses 1, it means it's not significant.
Exactly. Yes, exactly. You guys have to know these. You guys really have to know the definition of these. Okay, go ahead.
Yeah, as mentioned, there was no significant difference between on the primary endpoint of the death from any cause or disabling stroke at 2 years between the TAVR and the SAVR group. Rate of death from any cause was 16.8 after the TAVR and 18 after the surgery. The rate of disabling stroke was 6.2 in the TAVR group and 6.4 in the surgery group. In the transfemoral axis, the TAVR resulted in a lower rate of death from any cause or disabling stroke than the surgery, where in the transthoracic axis, the outcomes were similar.
This is very important sentence.
Yeah.
Why is that, Abdurrahman? Why is it extremely important to understand this statement?
So in cases of patients with peripheral artery diseases is either to go surgical or don't go with the TAVR, transfemoral access.
Yeah. So this is really important when you look at partner 3. From this, you understand if the patient you're going to do transapical or transaortic is almost equal to surgical AVR.
Yeah.
Okay.
Yeah.
Okay, proceed.
So the clinical endpoint of 30 days and 1 year, we can see here that the death from any cause was in the first 30 days 62 on the TAVR and 80 on the surgical group, where it's increased to 145, which represented 14.5% on the TAVR and 16 on the surgical group, and 19 after 2 years following up, it's representing as 19.3 in the TAVR and 21 in the surgical group. As well, we can see here that the disabling stroke after following up of 2 years, that shows that in the TAVR group 6.2 and the surgical group 6.4. So at 30 days, major vascular complication were more frequent in the TAVR group than in the surgical group, 7.9 compared to 5. Several other complications were less frequent in the TAVR group than in the surgical group, like life-threatening bleeding was 10 on the TAVR and 43 in the surgery. Acute kidney injury, 1 to 0.3 versus the 3.1 in the surgical group, and new onset atrial fibrillation was 9 to 26 to the surgical group.
That's true, but that did not affect the primary outcome, isn't it?
Yeah.
Okay.
Yes.
You just have to understand this. Okay, this has probably happened within less than 30 days, but it did not affect your primary outcome. Meaning, probably most of these things are reversible in the surgical group.
Yeah.
Okay.
So patients in the TAVR group had significantly shorter duration of stay on the ICU than did in the surgery group, where they stayed 2 to 4 days in the surgical groups. So there was no significant difference in the primary endpoint that compared the TAVR alone with the TAVR plus PCI, or surgical alone with the surgery plus CABG. So this schedule is showing the subgroup analysis of death from any cause or disabling strokes. We're seeing here that the surgery is better in the patients with left ventricular ejection fraction more than 55, better than the TAVR, and as we mentioned before, surgery is better in the more than transthoracic axis of the TAVR.
Yes. What do you call this thing? Graph, Anybody knows? Yes. Okay. Generally, this line, the dot, هذا يعطيك المين. أهم شيء, the horizontal line does not cross the midline. And then you can know it's favor TAVR versus favor surgery. But to me, by just looking at, none of them are significant. There is, the way you say it, Abdurrahman, there is a signal favoring surgery. There's actually none of them I could see actually statistically significant. This is how you read this graph. Okay?
Yeah.
Okay, proceed.
So on the echocardiographic findings, the aortic valve area and the left ventricular ejection fraction increased significantly, and the mean aortic valve gradient decreased significantly. The improvement of the aortic valve area and the gradient at all time points were significantly greater after the TAVR than the surgery. The frequency and the severity of paravalvular aortic regurg were greater after the TAVR than after the surgery. In the TAVR group at 30 days, mild paravalvular aortic regurg was observed according to the standard classification in 22% of the patients. Moderate to severe paravalvular aortic regurg in 3.7. They had high mortality during the 2 years of follow-up.
This is very important to know.
Yeah.
Okay.
So the main results from the partner 2, first thing, use of a lower profile next generation device was non-inferior to surgery with respect to outcomes at 2 years.
So just hold on this point. One of the things you guys have to understand, in the partner, they used only one kind of TAVI valve available in the market. Do you guys know what type of valve? So this is what they call the second generation. Okay, so you have to know that. The way you will interpret the result is for the balloon expandable SAPIEN XT second generation.
Yeah.
So you cannot reflect this result to other type of valves. This is very important to know. Okay.
Yeah.
Okay, go ahead.
So second thing, the incidence of paravalvular aortic regurg was higher after the TAVR more than the surgery. Several benefits, several benefits with regard to secondary endpoints were associated with TAVR, including bleeding, acute kidney injury, and AF, as well the short stay in the hospital.
Okay. But all of these did not affect your primary outcome, right?
Yes, yeah.
Okay.
The findings of the trial were similar between the groups. Outcomes for the endpoint of the death and stroke, although the possible superiority of TAVR over surgery in the transfemoral axis is a new finding for the balloon expandable transcatheter valve. The outcomes after the transthoracic TAVR were similar to or worse than those with the surgery group, and to be inferior to those in the transfemoral TAVR.
Okay.
The coronary revascularization was more commonly performed in the surgery group than in the TAVR group, 15 to 3.9, and the addition of either CABG or PCI to valve replacement therapies had no deleterious effect on the mortality or the rate of stroke. Although this trial was not powered or designed to address the issue of concomitant valve replacement and coronary revascularization. These results are counter to previous findings that the addition of CABG to the surgical aortic valve replacement resulted in a higher mortality. So in conclusion, intermediate risk patients with severe symptomatic aortic stenosis, surgical and transcatheter valve replacement were similar with respect to the primary endpoint of death or disabling stroke for up to 2 years and resulted in a similar degree of lessening of cardiac symptoms.
Just hold for now.
Yeah.
Don't go for the other one. Do you guys have any questions? طيب يا عبد الرحمن بسألك سؤال.
هلا. Yeah.
Let's say you're the primary investigator of partner 2. Now you're planning another trial, low risk.
Okay.
What things would you do in the design to prove that the TAVI is better than the surgery, than SAVR, for example? Based on your understanding of partner 2. قبل ما نشوف partner 3. أنت الحين خلصت partner 2 شفت عيوبها صح؟
Yeah.
Now you're designing partner 3. You want to prove بالdesign حقك إن التAVI is better than SAVR. What would you do?
So
وأنت تحط الdesign.
Yeah. First of all, I'll choose the patient carefully more than the partner 2.
Exactly.
Patient with lower chronic diseases or younger age,
Yes.
As well as the NIHA class of 2 or 3.
Yes.
They had no previous symptoms, or they had no previous procedures done for them.
Exactly. What else? What else? What are other things you could do? طيب الأكسس. احنا we compared two axes. What did you find?
I'll focus more on the transfemoral axis.
Oh, you exclude it totally. Don't focus. Exclude it totally.
I'll exclude the transthoracic axis.
صح?
Because it showed that there is no, it's inferior to the surgical. And the partner too.
Right? Okay, what else?
What about
حاجة بالديفايس نفسها.
I'll choose the new generation of the valves.
So if you design a new generation, what would you design be focus on?
The size.
التابي فيها مشكلتين كبيرتين. فيها access injury, صح؟
Yeah.
وفيها paravalvular leak.
Yes.
When you design the third generation TAVI, what would you do?
This size to avoiding the paravalvular aortic regurg.
Okay. And what else?
I'm not sure.
The third generation, it has a smaller sheath. Smaller sheath يعني less access complication. صح ولا لا?
Yeah.
2, the way they designed the SAPIEN 3 فيها زي قطعة الكلوث تحت من الفالف. Hopefully it will reduce the paravalvular leak. لأن احنا partner 2 قلت الناس اللي عندهم moderate to severe what happens to them. رجع صيداتك انت قلتها. رجع صيداتك. اللي عندهم moderate to severe paravalvular leak what happens to them?
They have high mortality.
Exactly.
Yeah.
So, as a designer of partner 3, this is what you focus on when you design partner 3. So this is really important to know, yeah.
Yeah.
Okay, you can start the second paper.
So, the previous randomized trials of the TAVR patients who were at intermediate or high risk for death with the surgery, TAVR was either superior or non-inferior to the standard therapy, including the surgical aortic replacement. There was insufficient evidence regarding comparison of TAVR with surgery in low-risk patients. That's what the partner 3 we're talking about. So partner 3, 1,000 patients were collected. The procedure was performed in 950. The mean age of the patient was 73 with an STS score of 4, mean of 1.9. So this is the characteristics of the patients was well balanced between the two groups. With the
but look at the mean age.
Yeah, 73.
And then look at the sex.
Yeah.
So what's the difference between the sex here and compared to partner 2?
The males here are more than the partner 2.
Why? Why do you think? ليش اختاروا ميل اكثر؟ بايست هم صراحه سكسست يعني. Why?
Females, I don't know, they consider it as a risk.
Female usually have very poor femoral access.
Vascular access.
Yeah.
Exactly. Okay.
And an STS score of 4, mean of 1.9. So the procedural outcomes on the TAVR procedure was converted to a surgery. One TAVR procedure was converted to a surgery, and one surgical procedure was aborted. Concomitant procedures were performed in 7.9 of the patients in the TAVR group and 26 of the patients with the surgery group. Concomitant coronary revascularization was performed in 6.5 in the TAVR and 12 in the surgical group. The surgery group, minimally invasive surgery was performed in 24 of the patients, and the surgical valve was 23 or larger in 79% of the patients. 6 deaths during the index hospitalization, which occurred in 2 patients with the TAVR and 4 patients in the surgery group. The concomitant procedure, we talked about PCI and the TAVR group PCI or pacemaker. The surgery group, most of the patients had cabbage, maze in 22, and LAA ligation and root enlargement. One of the patients had an ascending aortic replacement, and 6 of them had mitral replacement or repair. On the complication, as we mentioned, that procedural death was in 2 of the TAVR and 4 of the surgical groups. The interesting thing that coronary obstruction happened in 1 of the TAVR and 2 of the CABG group, as well as the ventricular perforation. Access of infection, of course, the surgical group will be higher than the TAVR group. The primary endpoint, death from any cause, stroke or rehospitalization, had occurred.
Can I hold you for a point? Are you going to talk about the exclusion criteria? The slide
Yes.
deck? Okay.
Sure.
Okay, proceed.
So death from any cause of stroke or rehospitalization had occurred in 42 patients in the TAVR group, compared to a 68 patients in the surgical group, representing 15%. So the non-inferiority and superiority were met with difference of 6.6 points. So the subgroup analysis of the primary endpoints.
ارجع slide ورا.
Okay.
I'm just going to explain this briefly. Now, the way they do it, they design as a non-inferior trial. بس إذا كانت difference عالي جدا بيقول لك خلاص هذه superiority trial. باختصار يعني. I really don't know how I feel about this design يعني, بس I guess you can say it. تقول مثلا هي non-inferior and the null hypothesis تكون إنه there is no there is a difference, صح؟ الquestion حقك تقول there is a difference. انت you're just gonna reject this. But انت تقول لو لقيت فرق 6.6 لا بتكون superiority. This is the way they design it يعني. I'm not a statistician, but design زي كذا أنا شوية I wonder sometimes if it's true or not. هذه حاجة you have to take in account, صح ولا لا؟ Okay, go ahead. هذه بس فكرة حبيت I wanted to share يعني. Go ahead. Hello?
Yes, doctor, we hear you. Maybe our colleague here.
I think we lost him, so let's call him and see.
Dr. Abdullah, I have one question.
Yes.
These studies were all designed to be for non-inferiority. What would the designer change in the study design to make it for superiority?
I'm not sure. I don't know how can I answer your question, to be honest with you. I know the concept of it, but you have to prove يعني انت لازم تقول ان التريتمنت اللي موجوده is not optimal. What I'm providing is the best treatment. بشكل عام يعني as an idea.
Okay, I see. I have also one more question, which is regarding the sequence. For me, it seems more logical. Like if, let's say I want to make this study, I would first, because what I understand from you, doctor, is if you want to use a superiority, you would use a new treatment and compare it to a placebo to make sure it's superior.
Yes.
But if there is an already established treatment, you will first do an non-inferiority.
Yes.
Why haven't they tried, after they proved that TAVR is non-inferior, let's say in partner 1 in high-risk patient, why haven't they done another study that proves that it's superior to surgical?
I'm not sure, to be honest with you, but I'm just, there is a thing with TAVI that we don't know till this point, but we know with surgery. He has survival in 5 to 10 years.
Yes.
هذا السؤال احنا we cannot answer currently with good evidence. وبارتنر 1 ما ادري بس كانوا high risk يمكن none of them survived to 5 years Maybe if you proved that the mild paravalvular leak is not affecting the survival of your patient in 5 to 10 years, I guess you can design a superiority trial, maybe. Then the biggest question for TAVI are two things. The effect of the paravalvular leak on the long term, واحد. اثنين, a lot of patients experience thrombosis في الvalve ويجون بstroke. Currently, there is no universal way of managing their antiplatelet / anticoagulation post-operatively. The trial هذه partner 2 لو تقرون details, all of them just stuck with aspirin Plavix for 1 month. Plavix, but they stop Plavix after a month. Is that optimal? I don't know. Currently, if it was my patient, I'll just keep them on aspirin Plavix for life, because I don't know, because I know some patients come back with strokes.
But if a lay person read, let's say, the partner 2 trial, it would be misleading. It
exactly.
says
that's why we're criticizing this trial. عشان كده I'm highlighting certain points to you guys. That's why we're doing the journal club. That's why we're reading it. Partner 2 is fine, but partner 3 is more important. لأنها هي وظهر في واحدة ثانية للكور فالف. لو تقرأ التايتل بيقول لك حط هذه لكل الناس. Which is not true currently I don't know, maybe in the future
I see.
Abdurrahman Rajat?
Yes, sorry. So I had some trouble with the connection.
It's okay.
So this is the table of subgroup analysis of the primary endpoint at 1 year. Showed
what was one of the most important exclusion criteria? Partner 3 في الvalve نفسها. Do you guys know? في aortic valve.
You mean the exclusion, the bicuspid valve?
Exactly.
You should,
It's extremely important for you to say that. Why? What's the problem with bicuspid valves?
The diameter and the size of the aortic annulus and the aortic valve is changing from the tricuspid valve.
If we brought 2 patients عندهم واحد tricuspid واحد عنده bicuspid وخذنا cross section, كيف شكل الانيولس في الbicuspid compared to the tricuspid?
It's more like oval.
So what would that result in?
Paravalvular regurg.
Exactly. Okay. So they excluded all bicuspid valves. Very important to know. Okay.
So the TAVR group as compared with the 2.5 in the surgery group for death from any cause to 1.2 as compared with the 3.1. So the secondary endpoints at 30 days, the TAVR resulted in a lower rate of stroke than the surgery, 0.6 to 2.4 in the surgical group, and lower rate of death or stroke 1% to 3.3 to the surgical group, and the new onset of atrial fibrillation, the TAVR group was 5 versus the 39 in the surgical group, as well as results in a short index hospitalization than the surgical, the TAVR patients stayed for 3 days compared to 7 days in the surgical group. At 1 year, the rate of death or disabling stroke was 1% in the TAVR group compared to 2.9% in the surgical group. The percentage of patients who were discharged to home or self-care was 95 in the TAVR group compared to 73 in the surgical group. There was no significant difference between the two groups with regard to most safety endpoints at 30 days, including...
عبد الرحمن أنت تكلمت بس على الديث per se.
Again, what?
بس الديث. في جراف تكلم بس على الديث.
Yeah.
Only death.
Stroke and...
No, death only.
Yeah.
اوكي روح للديث from any cause في الجراف الكابل ماير سرفايفل كيرفز ارجع ورا الظاهر انت عندك سلايدات اللي موجوده بالبيبر يعني. طيب شوفها B death from any cause. Yeah. Look at the hazard ratio, look at the confidence interval. What does it tell you?
There's no difference between the two groups.
Exactly. So the primary outcome was mostly driven by what?
Death from
stroke.
Stroke.
صح ولا هو composite صح ولا لا؟
Yes.
هو composite. فكان الدرايفر ايش؟
The stroke.
حلو؟ واضح؟
Yes.
بعدين شوف rehospitalization.
Yeah. There is a huge difference between. Yeah.
صح. These trials, what happens to the stroke after a year or two? أغلب الانترفنشن trials اللي شفناها في حياتنا كلها.
I'm not sure.
They equalize.
Oh yeah.
الستروك دائما أعلى في السيرجي في البداية بس with time they equalize.
With time they will be equalized. Yes.
صحيح. إذا صار البارافالفولار ليك المايلد causing heart failure بعد سنة. What happened to rehospitalization?
You've increased equalization also.
صح ولا لا؟
Yes.
شوف الكيرف عشان تفهمون الكيرف. مثلا الديث كان السيرجي على طول في البداية بسرعة طالع الكيرف صح؟
Yes.
وبعدين صار بلاتو. نفس الشيء الستروك. شفت ستروك بس بالبداية.
Yeah.
يعني mostly perioperatively ولا short post operative period بعدين بلاتو صار.
Yes.
ما صار يطلع فوق. ونفس الشيء rehospitalization. mostly هذول الشياب جاء wound infection ولا حاجة ورجع المستشفى بعد 20 days. Not necessarily عنده heart failure. ممكن عنده wound infection صح؟
Yes.
فبعدين يصير له بلاتو. What happens a lot of the trials البلو لاين بعد سنة أو سنتين أو 3 أو 4 they cross.
Yeah. So that's why we need 10 years follow up.
Exactly. دائما مشكلة السيرجيكال ترايل دائما بالبداية المشكلة. بعدين with the long term they plateau. Okay.
Yeah. So the echocardiographic findings at 30 days, the mean aortic valve gradient was 12.8 in the TAVR group and 11 in the surgical group. The mean aortic valve area was 1.7 in the TAVR and 1.8 in the surgical.
غريبة أكبر ها؟ هذا من الحاجات اللي أنا استغربتها. Okay.
The percentage of patients with moderate to severe paravalvular regurg did not differ significantly between the TAVR and the surgical group, opposite to the partner 2.
That I wonder what kind of valve they used. But anyways, surgery should not have paravalvular leak.
Yeah.
لأن ما في surgeon يطلع moderate to severe من اللغة. ولا أنا غلطان؟
Yes, I agree.
Okay.
So the percentage of patients with mild paravalvular regurg at 1 year was higher in the TAVR compared to the surgical group. 29 to 2. Yes.
Okay.
So the main findings of the trial, first thing, TAVR performed by mean of transfemoral placement of the balloon expandable sapien 3 system with superior to surgery with regard to the primary composite endpoint of death, stroke, or rehospitalization at 1 year. Results for the 3 components of the primary endpoint favored TAVR at both 30 and 1 year. TAVR was associated with significantly lower rate of new onset AF at 30 days, a shorter index of hospitalization, lower risk of poor treatment outcomes at 30 days than surgery. Patients who underwent TAVR had more rapid improvement in the NEHA class. The surgical outcomes in the surgery group, the rate of death at 30 days was 1.1, and the rate of composite of death or disabling stroke at 1 year was 2.9. In the TAVR group, the rate of death at 30 days was lower, 0.04, and the rate of death or disabling stroke at 1 year was 1%. So the complication that were more frequent with the TAVR than the surgery in the previous trial occurred with similar frequency in the 2 groups, including the major vascular complication, new permanent or pacemaker insertion, moderate to severe paravalvular regurg, coronary obstruction, or life-threatening bleeding. It occurred less frequently with the TAVR than the surgery group. So results for other secondary endpoints, including new left bundle partial block and mild paravalvular regurg, favored the surgery. So between group differences in the transvalvular aortic valve gradient also favored surgery, although this was not the case in the previous randomized trial of the TAVR. This result was probably due to the greater use of larger surgical valve in this trial. So the limitations of the trial, the most important limitation of this trial, current results reflect only 1 year outcome. The results apply only to the defined trial population, which excluded patients with poor transfemoral access, bicuspid aortic valve, or other anatomical or clinical factors. More patients in the surgery group than in the TAVR group withdraw from the trial. Missing data were not fully accounted for the multiple imputation. This analysis did not examine the rate and the relation of asymptomatic valve thrombosis. So the conclusion, patients with severe aortic stenosis who were at low risk for death or with surgery, the rate of composite of death, stroke, or rehospitalization at 1 year was significantly lower with the TAVR than the surgical aortic valve replacement. Yes.
لو أنت في العيادة وجاك مريض محول من الكارديولوجي عمره 55.
Yeah.
وسيفير سيبتماتيك اورتيك ستينوسيس. جاك العياده وقال لك يا دكتور عبد الرحمن ابغى تابي، ما ابغى سيرجيكال اي بي ار، وش تقول له؟ وبعدين هو طلع من موظفين ارامكو يعني متعلم وقاري ترايلز وجاي متسلح يعني قاري نيو انجلاند جورنال، يقول لك يا عبد الرحمن انا توني فاتح نيو انجلاند ولو ريسك وابغى تابي، غير تابي انا بمشي، وش تقول له؟
Okay, I'll be honest with him that according to the partner trial, the TAVI is not non-inferior to the surgical group, to the surgery in the low-risk patients, but it's only for 1 year following up. We need more up to 10 years follow-up to have a clear idea about it. Yeah, I'll be honest with him that. Yes.
Anything else? number 55 رجال.
And according to the guidelines, the surgery is more.
الرجال طابع لك النيو انجلاند ترايل وحط لك اياها في المكتب، بيقول شوف الكونكلوجن. ايش تقول له؟
بكون صريح معك بقول انه التابي اوكي not inferior to the surgery بالعكس ممكن تكون superior لها في يعني according to the partner trial which is only 1 year following up. لكن بالمستقبل والله ما ندري ايش راح يصير. according to him, according to the guidelines, 55, I'll prefer the surgery for him.
Okay. Any of you guys want to add anything للمريض هذا تقولوا له؟ Anyways, so you should tell him what you said is correct. You should add also, and the mean age can 71.
Yes.
It's 55. هذا 15 سنة difference.
Mm-hmm.
صح ولا لا؟ A guy who's 71, the mean age في السعودية 76 مثلا.
Yeah.
This guy is expected to live 20 years. صح ولا لا؟
Mm-hmm.
You tell him that information. And the trials هذه كلها كانت على ناس كبيرين في السن. It does not really apply to you and your level of activity. لأن هو level of activity بتكون probably higher.
More than, yes,
صح ولا لا؟ السؤال هنا المايل بارفيرال ليك would that affect his activity؟ هو عمره 55 لسه باقي له 5 سنوات ما تقاعد صح؟
Yeah.
So you have to also explain that to him. صح ولا لا؟
صحيح.
Plus زي ما قلت long term outcome. Another thing انت في جمله مبطنه حطوها بس ما شرحوها مثلا ارجع السلايد الاخير ارجع كاتبين this analysis did not examine the rate of annulation of asymptomatic valve thrombosis.
Yes.
طيب وصل للsymptomatic valve thrombosis ايش ما تكلمتوا عنها؟ most likely لما في حاجه اسمها index of paper most likely تكلموا فيها بس كان الانسيدنس of valve thrombosis not that significant. But it's concerning صح؟ ممكن تكون a problem تبين بعد سنة أو سنتين.
Yeah.
You have to tell him this information too.
صحيح.
Yeah.
Any question from the audience?
And lastly, you have to tell him if we can do it transfemoral طبعا.
Yeah.
ما يجي ما يجي ويصر على تابي بعدين يطلع الفيمورال حقه 5 سم ولا 4.5 وما يخش الشيء.
Yes.
Does not apply to him.
So any question from the audience?
Why such a patient will be referred to surgical team since he is not convinced at all with surgery? So what I'm gonna do for him يعني convince him? He doesn't want a surgery. He is refusing.
ما هو refusing. He has a symptomatic aortic stenosis.
Yeah.
And he's an intelligent gentleman, an engineer ولا general manager. وزي أغلب الناس الحين they go online they search صح؟ And he needs a solution. TAVI is part of you guys to know. The surgeons should do TAVI. فبيجيك الكلينيك and you do both surgical AVR or TAVI. And he asks you for the less invasive. He wants a solution, but he wants the less invasive solution. The way you answer him in that this trial does not apply to him, but surgery is better in the long term and his risk is low. يعني هو كم يطلع الاس تي اس سكور حق الرجل هذا اللي عمره 55 جاي فور اي في ار؟
less than 1 point something.
Exactly. Sometimes إذا ما عنده coronary disease, normal kidney function, otherwise healthy, بيصير less than 1%. كم كان
The mean was 1.9.
So that patient did not refuse intervention. He wants an intervention, but a less invasive intervention. That's all.
Yeah, because lots of patients we discussed, somebody will present the case and then he will tell you that patient is want a less invasive. All patients want less invasive, but you have to find something any beneficial for the patient. Yes, we know all patients they want a less invasive procedures. They do want their sternum to be cracked.
Yeah.
Any other question from the audience?
So, Dr. Abdullah, would you do a TAVI for him if he insisted, even though you are not convinced that it's the right option?
Probably not. Probably not. 55? Probably not. Probably not. طبعا ما راح بيكون احنا in the era of heart team. I'm not going to present him that I refused him per se. What you could do, you could تقول احنا we discussed in the heart team meeting for these following reasons we don't think you are a good candidate. And you get say it in a nicer way يعني تقول احنا we are funded for 20 valves. We have sicker patients that we rather use them in. Yeah. طبعا at the end of the day he has all the right and يروح private يحط له TAVI valve which is fine. But that happens. وهذا بدأ يصير في الستيت. بعد البارتنر 3 صار يحطون TAVI البرايفت لأي أحد يدخل الباب يعني.
Which is unfair for the patient.
That's fine, but this is what he wants. It's FDA approved. But I wouldn't. But I would not يعني I'll word it in a nicer way. ما راح أقول لا ما راح أحط لك TAVI. يعني you have to be nicer يعني مع الله.
Okay, so I would like to thank Dr. Abdullah Tebi for joining us for the Today Journal Club. And thank you guys. Luay?
Yes, thank you, Abdulrahman. Nice presentation. Dr. Abdullah, thank you for this nice comments and hope we'll see you more, inshallah.
I have one question, Luay.
تفضل دكتور.
دكتور عبد الله، دكتور عبد العزيز من مدينه مكة الطبيه في الرياض. دكتور عبد الله, if you have a patient with 35 years old and he has a contraindication to mechanical valve, what do you prefer?
Contraindication
or bioprosthetic valve?
Ross. If he's a candidate of Ross, he goes for Ross for sure. 100%. إذا هو عنده خاصة إذا كان عنده congenital bicuspid stenosis ما عنده annular dilatation 100% Ross. I refer him for a surgeon who does a lot of Ross. أوديه زهير الهليس. If he wants a tissue valve وهو مصر أو contraindication, you just do a tissue AVR and you be clear to the patient that after 7 years or 8 or 10 if you're lucky we'll do a redo AVR again.
What do you think about the valve? يعني دكتور مثلا TAVI and valve later on. Valid option or no?
Logically, what's the problem with valve and valve?
It will
intervention.
Yeah, it will insert the valve inside the valve. It will cause. I think yes. It will cause.
Yeah, what that result in what? ماذا يحدث مع الفالف and valve؟ فيها مشكلتين كبيرتين.
Heart block maybe and.
لا ما في heart block. أنت تحط فالف على فريم موجود. ما في مستحيل. في حاجتين حلوة في الفالف and valve. ما راح يصير conduction abnormality وما راح يصير paravalvular leak. No way.
I think smaller diameter
across the valve.
So smaller effective orifice area and
also the risk of thrombosis will double.
Yes, thrombosis. Sometimes, not all prosthetic valves are amenable to valve and valve. ليش? Sometimes يعتمد على height with the way you design it. Sometimes لو سويت valve and valve you can block the coronaries.
Yeah.
So you have to know what kind of valve وكيف شكل الليفلت. But you almost impossible تحصل paravalvular leak مع valve and valve وconduction never happens. وما تحتاج تعمل ballooning يعني حتى أسهل. Valve and valve is actually not a very difficult thing to do يعني. But the problem is you end up with a smaller effective orifice area. And the second issue, you don't know what's the long-term outcome of it too. يعني مريض عمره 35 I can give him a tissue valve. لما يصير عمره 45 أعطيه another tissue valve. لما يصير 55 وكان high risk for a third redo ممكن أحط له TAVI يعني. But he probably should go for Ross. To be honest يعني. لأن Ross with valve conduit ممكن يعيش ل 20 سنة ما عنده مشاكل يعني. وبعدين اذا خرب التي اي كوندويت يحطوا له اميليدي فالف ولا اورتك he can have a redo AVR or a TAVI or whatever works in the future يعني.
اوكي thank you دكتور عبد الله thank you.
خلاص انتهينا؟
Yes, I think so.
يعطيكم العافية يا شباب.
يعطيك العافية دكتور عبد الله.
مع السلامة.
Thank you everyone and see you next week.